Before I'd start, I'd like to begin by acknowledging the Dharawal people as the traditional custodians of the land from where I am joining today, just south of Sydney. I pay my respects to their elders, past and present, and acknowledge their continuing connection to land, sea, and community. I also extend this acknowledgement to the traditional owners of the many lands from which we are all joining today. I'd also like to acknowledge the individual and collective expertise of those with a living or lived experience of mental ill health, distress, trauma, and suicide. We at the Commission recognise their vital contribution at all levels and value the courage of those who share this unique perspective to help us achieve an Australia where every person has the opportunity to lead a life of meaning and purpose. These acknowledgements are particularly pertinent to the topic that is the focus of today's webinar, namely the draft National Stigma and Discrimination Reduction Strategy. We know that stigma and discrimination related to mental ill health is still experienced by too many people. We also know that these experiences can be compounded for particular groups and individuals in our communities who may experience other types of stigma and discrimination, such as on the basis of race, culture, disability, gender, sexual identity, and other aspects of identity and experiences. Our work to develop the draft strategy has really sought to recognise the deep diversity and intersection of these experiences and to put forward a range of practical actions that can move us towards a future where mental health related stigma and discrimination are no longer barriers to lives of meaning and purpose for all Australians. So the purpose of today's webinar is not as a consultation, but rather to provide some background and an orientation to this rather lengthy document that is the draft strategy, and as a way to guide and support your engagement to help inform us as Commission as we work to refine and finalise the document. Today, we'll also hear some reflections from people who we have been lucky enough to work with closely as we've been developing the draft. On this point, I'd just like to note that we will be hearing from just 4 of the more than 60 odd people who have generously given their time, experience, expertise and guidance through all of our governance committees to shape the draft strategy and our approach to its development. On behalf of the team, I'd like to extend a heartfelt thanks for bringing your passion, honesty and commitment to this work. I'd also like to extend thanks to the countless number of other people who have made significant contributions to this work, including those who undertook research for us, organisational and sector leaders, service providers, and the many members of the public who have been involved in online workshops and other conversations along the way. Across all these contributions and contributors, I'd particularly like to thank those with personal lived experience and those who are family members and support people for sharing your time and perspectives. So for today's webinar, we're going to start with a presentation from Dr. Michelle Blanchard, who is Project Lead and Executive Director of Strategic Projects here at the Commission. We'll then hear from 4 panellists. First up will be Tim Heffernan. Tim is a lived experience leader with substantial experience within New South Wales as well as nationally. Tim is Deputy Commissioner with the New South Wales Mental Health Commission, an experienced peer worker, and has been at the forefront of a number of consumer-led initiatives in research, advice and system reform. Tim is co-chair of the Strategy Steering Committee and today will provide some reflections from the perspective of personal lived experience. Next up, we'll have Margaret Doherty. Margaret is an experienced advocate for individuals and families with experiences of mental distress, alcohol and other drug use, and involvement with the criminal justice system. Margaret is a member of our public Stigma Technical Advisory Group and will speak from her perspective as a family member and support person. We'll then hear from Tony Clarkson. Tony is trained as a psychotherapist. He's former Vice President of the Psychotherapy and Counselling Federation of Australia and is currently working in the space of gambling harm. Tony is co-chair of our project Self-Stigma Technical Advisory Group and will offer some reflections on the project as a health practitioner. And then finally, of our 4 panellists, we'll hear from the Honourable Kevin Bell, AM, KC. Kevin is a professor and former director of the Caston Centre for Human Rights Law. He was a Justice of the Supreme Court of Victoria for 15 years and is currently a member of the Uruk Justice Commission. Along with Tim Heffernan, Kevin is co-chair of our steering committee and will talk to the centrality of human rights as a foundation for this work. So we'll kick off really shortly, but a little bit of housekeeping before we do. Just noting that this webinar is being recorded so that we can make it available online for other people to view after today. Live captioning is available, which you can turn on or off by clicking the button that should be at the bottom of your screen. We'll also be making the transcript available alongside the video recording. Today, the chat function is not available. This was a decision we made so that we could record today's session while also protecting people's privacy when we do share that webinar recording online. But through this webinar, we really do encourage you to use the question and answer function to submit any questions you might have along the way. Only the Stigma strategy team and panelists will be able to see these questions as they're submitted, and you can submit the questions anonymously. Our plan is to consolidate and respond to these questions in a FAQ or frequently asked questions resource that will be uploaded to the Commission's website. You can also get in touch with our team at any time via email to stigmastrategy@mentalhealthcommission.gov.au, and we'll endeavour to respond as soon as we can following the webinar. So without any further ado, I'll pass over to Michelle, who will start us off with an overview of the draft Stigma and Discrimination Reduction Strategy. Thanks, Michelle.
Thanks so much, Emily, and thank you so much to everyone who's joined us on the line today for this briefing on the draft National Stigma and Discrimination Reduction Strategy. As Emily said, we have been incredibly grateful to have worked with such a fantastic group of lived experience leaders, families and support people and other experts as part of the development of this draft strategy, and hope that what we're presenting to you today gives you a really strong sense of the process that we've undertaken to develop this draft strategy, a bit of an orientation to the strategy itself, which then hopefully will enable you to be able to respond to the draft strategy as part of the public consultation process. So to take you back to where this particular project started, the National Mental Health Commission was tasked back at the end of 2020 by the National Federation Reform Council, which sits as part of National Cabinet, to develop this particular strategy. And it was one of the first pieces of mental health reform that was committed to by the former government in response to the Productivity Commission inquiry into mental health. And I think that's particularly important context because it recognises that not only is it important for us to create services and supports in the community that meet people's needs, but we also need to build an Australian community that values and supports people who experience mental ill health and distress and the folks who care for and support them. So we've got, if you like, two arms of a coat hanger, and we need to really ensure that we're focusing on both to be able to make a difference. So this particular strategy recognises that stigma, prejudice, discrimination are not new concepts. In fact, people with lived experience have been telling us for decades that stigma, prejudice and discrimination continue to be really significant barriers that they face. And this work builds on efforts by people with lived experience, by families, friends, carers and support people, and a range of organisations to tackle stigma and discrimination over a sustained period of time. But the particular goal that we had in doing this work was to develop up a strategy which articulates some clear priorities, focus areas, objectives and actions that government and other parties can take over the next 5 years to help us tackle stigma, prejudice and discrimination in a really coherent and cohesive way. A lot of our previous efforts have focused only on part of the problem. And so we felt it was really important in undertaking this work that we focus not just on public stigma, so on changing the attitudes that the community might hold towards people who have personal lived experience and their support people, but that we also focus in on taking action towards eliminating structural stigma and discrimination and to reducing self-stigma, so changing the way that we feel about ourselves when we ourselves encounter a period of mental ill health or distress. I wanted to recognise that throughout this presentation, we'll tend to use the phrase personal lived experience to describe a range of experiences people might have. People make sense of these experiences in different ways. They might describe them as a period of mental ill health, a period of distress, a response to trauma, an alcohol or other drug issue, an experience of gambling harm. There are lots of different terms and phrases. And so we've chosen personal lived experience as a way of broadly describing a range of experiences and hope that people can see their own experiences reflected somewhere in that broader definition. The reason why we've come at this problem in terms of addressing self-stigma, public stigma, and structural stigma and discrimination is really to recognise that these are interacting and reinforcing systems and processes. So the way that we feel about ourselves when we encounter our own experiences of distress is informed by what we know of the attitudes that the people around us might hold, and how we think we might be treated by systems and institutions when we come in contact with them. So tackling all of these forms of stigma and discrimination are incredibly important. And in particular, focusing in on changing structural stigma. So this is the kind of discrimination that develops when laws, policies, practices, and organisational structures enable the unfair treatment of people with personal lived experience. It can be intended or unintended, but the end result is that people experience unfair treatment or discrimination. As Emily said at the outset, we've been really grateful to have the opportunity to work with so many different people and organisations as part of this work. And in particular, we were grateful to have the support of the Behavioural Economics team of the Australian Government. We call them BETA for short, who are a unit within the Department of the Prime Minister and Cabinet, who do a range of initiatives that help to understand human behaviour and what that might mean for public policy. BETA worked with us to do a survey of just under 8,000 people in the Australian community using a panel through the Social Research Centre to ensure that those who participated were broadly representative of the demographics of the Australian community. There were certainly some findings in that BETA survey that gave us some cause for optimism, and in particular, people's desire to be supportive and understanding of those who might be experiencing distress or encountering a mental health problem or a period of lived experience. And there was a really strong desire from the community for things to change. 83% of those surveyed felt that more needed to be done to eliminate discrimination towards people affected by mental health problems. And 84% of those surveyed felt that more needed to be done to improve the way that mental health is dealt with in the workplace. Unfortunately, though, the research did also give us cause for concern. And I wanted to flag that some of the views that are expressed on the next slide we found particularly confronting and challenging, and particularly for those of us in the team who have had our own periods of distress or have cared for or supported people in our lives. This slide not only is confronting, but it also gives us motivation for change and the reason for the work that we do. And that's that we found that levels of stigma and discrimination in the Australian community was still very, very high. There are some experiences that tend to be more frequently stigmatized. So people whose experiences might be described as schizophrenia or borderline personality disorder tend to experience stigma and discrimination more frequently. And we noted that the kinds of stigma that people held, the kinds of attitudes that people held, tended to differ based on the experiences people had. So we feel differently towards someone who experiences an eating disorder than we might do to someone who hears voices. And so it's really important in doing this work to reduce stigma and discrimination that we are understanding the differences in experiences people might be having, the different kinds of beliefs people might hold, and how that might be impacting the experiences people are having in the community. We also found that there are some stigmatizing beliefs that are much more frequently endorsed in the community. We found that it's now far less common for people to see an experience of mental ill health or distress as a personal failing. But unfortunately, it was more common for people to perceive that the person was at the whim of something that they can't control. And this is particularly important because unfortunately, it drives some of the really stigmatizing and prejudicial beliefs that people might hold, things like people being unpredictable or dangerous. We found that this tends to be more common when there's an overemphasis on the biomedical basis for mental ill health. So where people understood periods of distress as resulting from biology or resulting from an illness, they tended to hold more stigmatizing views. But if they saw people's experiences as part of the human experience, as a response to circumstance or a mixture of biological, psychological, and social factors, people tended to have a more understanding and empathetic view. So it's really important as we think about stigma reduction initiatives that we avoid this in and out of control idea. We actually found that it was less helpful to draw analogies between physical and mental health problems or mental illness and physical illness, that actually these issues are very, very different. And so kind of trying to create this comparison between them might actually lead to some of the myths that people tend to hold. It's also really important that we present a really diverse range of experiences of what managing recovery might look like, so that people can see that a good life with an experience of distress or a period of lived experience is incredibly important, valuable and meaningful for a lot of people. We did also find that there were some demographic factors that were more frequently associated with stigma. We found that there were higher proportions of people who endorsed stigmatizing beliefs amongst men, amongst younger people, and also amongst people from culturally and linguistically diverse backgrounds. I'd put a really big caveat on that third finding, though, that very few of the tools that are used to understand stigma, prejudice, and discrimination take into account the different ways that different cultural communities understand and make sense of distress. And so it's really important for us to develop far more targeted and tailored interventions and supports for these communities, and also ensure that in our contact-based interventions, so contact interventions are where we increase the visibility of people with lived experience, where we hear people's stories, where we have the opportunity to build empathy for their experiences, that we're portraying and representing a broad range of people and experiences in those conversations. So In addition to the work that we did with the behavioural economics team, we also commissioned a number of pieces of research to support the development of the strategy. We also utilised some work that had been done by the University of Melbourne previously under the 5th National Mental Health and Suicide Prevention Plan called Misread, which was particularly around understanding experiences of stigma and discrimination and opportunities to intervene where people might be experiencing more complex mental health need. We commissioned a number of literature reviews looking at understanding and addressing the different forms of stigma, but we also did a couple of deep dives into particular areas where we knew that people experience stigma and discrimination more frequently, whether that be in social security and income support, with respect to the insurance industry, in the legal and regulatory context, so needing to understand more about how anti-discrimination laws and human rights legislation operate in practice, the experiences of people who might be in contact with the criminal justice system, as well as family court and child protection processes. And there were actually 2 pieces that we did around the insurance industry. We combined those inputs with the input of our governance groups, which really tried to centre lived experience leadership. So we established a steering committee, and you'll hear later on from both Tim and Kevin, who are the co-chairs of our steering committee, as well as some of our technical advisory group members. And we deliberately set those up in a way where they were co-chaired by people with lived experience and people with other forms of expertise in the places where we were trying to create change. And we felt that that was a really important approach because lived experience leadership is absolutely key to delivering change in reducing stigma and discrimination. But it's also everyone's responsibility to call out stigma and discrimination where it exists. It can't always be on the community that is being stigmatised, being marginalised and being discriminated against, to always be calling out this stigma and discrimination when it occurs. It actually needs to be on all of us to take action to try and create change. So we built on the engagement of our steering committee and our technical advisory groups, the work that was done through the beta team, and also our commissioned research. And we held a series of online workshops in November of 2021, so a year ago. We had a mixture of participants, including folks with lived and living experiences, family, friends, carers and support people, as well as others with a stake in solving issues relating to stigma and discrimination, who participated in working with us to understand more about these issues, but also to start to explore some of the potential solutions. In early 2022, we undertook some specific pieces of engagement with leaders in culturally and linguistically diverse communities, but also with Aboriginal and Torres Strait Islander leaders to really try and understand more about how we experience how different communities experience stigma and discrimination, and where we can take further action. Over the last few months, we've been undertaking some really intense engagement with some of our key stakeholders, and we've now just opened up the strategy for our public consultation period. The draft strategy itself outlines a vision for an Australian community where people with lived experience have equal dignity, value and respect, and that everyone's able to live a life of meaning and purpose, free from mental health related stigma and discrimination. This language around a life of meaning and purpose, it was chosen quite deliberately with the input of our steering committee and advisory groups, because it's language that they saw to resonate for everyone, regardless of where they might be in their experience of recovery. And so really, rather than trying to focus on a vision of people being productive or contributing, which is often where some of this work is framed, that often relies on an external perception of what is productive or what is contributing. But this is more about a sense of meaning, a sense of purpose that has that connection for the individual, but also for the people that might be around them. The strategy is guided by a series of guiding principles that we developed with our steering committee and technical advisory groups. And we spent a long time trying to get this right. And we really focused in quite significantly on the human rights approach and the importance of upholding and protecting the dignity and human rights of people with personal lived experience and those who support them. That means that we respect and promote a person's autonomy, agency, and voice, and also the leadership role that people with lived experience play in all aspects of the strategy. And we hope that extends not just from the development of the strategy, but into its finalisation and implementation as well. We also wanted to value and promote the unique and distinct role, needs and experiences of family, friends, unpaid carers and support people. And what we really wanted to emphasise here is that families and support people also experience stigma and discrimination, but their experiences are unique and different from the experience of the person that they might care about or love. And so wanting to really recognise the differences there. And that's particularly important in understanding that different people have different experiences of how they've been treated by family, friends, and people around them. So wanting to really draw that distinction there. We also recognise that for a whole range of people in the community, there is a compounding effect of other forms of stigma and discrimination. If you're also facing racism or homophobia, transphobia, sexism, these forms of stigma and discrimination mean that not only are you at increased risk of experiencing distress or encountering a mental health difficulty, there might also be additional barriers that are in your way when you seek support or when you engage with a range of systems and institutions. So it's really important for us in this work to understand, respect and support culture, spirituality, identity, intersectionality and community. And of course, really critical for us to measure change to drive accountability. There have been lots of attempts to address stigma and discrimination, some really promising work, but also lots of things that haven't worked. And so it's really important that we are keeping track of what does and continuing the things that show promise. So the draft strategy document that is out for consultation at the moment outlines how to create change at a couple of key levels. It identifies some specific actions and some intended change that we'd like to see in the community. We originally started off by focusing in on actions under each of the three areas where we were looking to see change. So around self-stigma, around public stigma, and around structural stigma and discrimination. But as we were working through, it became very clear that what we needed were some actions that sit at a foundational level. There's a real need to strengthen our human rights and anti-discrimination legislation so that it's fit for purpose in addressing and meeting the needs of people with lived experience of mental health related stigma and discrimination. We need to strengthen some of our accountability mechanisms so that they have teeth. We really need to improve our evidence base through evaluation and monitoring and embed both lived experience leadership and advocacy. There's opportunities for us to train and build the capacity of a range of workforces that might interact with people with personal lived experience and their families and support people. And that's needed across a range of settings. So in the document, as we look at actions to reduce structural stigma and discrimination, you'll actually see that we've made recommendations with respect to a number of settings. So that includes the mental health and health systems. We know there's still places where people encounter frequent stigma and discrimination. There are recommendations with respect to employment and workplaces, education and training, social services, income support, and the disability sector. There are also recommendations with respect to the justice system. So we've tried to look at each of the different settings where people might be encountering stigma and discrimination and have made recommendations in each of those. We've made some recommendations around actions targeting public stigma. And in particular, I wanted to reinforce that these recommendations go far beyond a campaign or awareness raising. What we know from the evidence is that campaigns and awareness raising alone will not make a difference in addressing stigma and discrimination. We also need our lived experience leadership and advocacy. We need our legislative and our structural changes. And we also need to focus in on some practical action that change the systems and institutions that often, whether they mean to or not, perpetuate stigma, prejudice, and discrimination. We also know that creating change in cultures takes time. So the strategy has timeframes against each of the actions. Some are short term, so within a year, some are medium term, and some are longer term. But we know that 5 years will not be enough time to create all of the change that we are recommending. And so it will be really, really important for this strategy to be monitored and evaluated. And we anticipate that it will be the first in a series of strategies which enable us to create sustainable change over time. So as we mentioned, we have opened up the strategy for public consultation. The strategy will be open for comment through to the 1st of February next year. And there's a couple of different ways that people can participate in that consultation process. There are a number of online surveys inviting feedback on actions from individuals, and we particularly encourage individuals with lived and living experience to complete that survey. There are specific survey questions for families, for carers and support people, so recognising those different experiences. And also another one targeting particular workforces where we're keen to understand some of the barriers and enablers to stigma-free practice. We welcome submissions from individuals or organisations in a range of formats. That might be your traditional written submission, but we've already received some poems, we've received some other documents that people have wanted to share with us, and we really welcome all of that feedback in whatever form it takes. The team are available to do briefings just like this one. And of course, we'll make sure this recording is available for people throughout the consultation process so that everyone has that background information. And we are looking to do a series of very small and focused roundtables where it might be helpful for us to dive deeper into particular topic areas. In doing the consultation, we really want to explore whether the actions we've recommended are feasible. Are they allocated to the right party? Is there going to be a readiness for change, or are we going to come up against a whole bunch of barriers? What are those barriers, and what are those enablers that might allow change to occur? Will the actions actually lead to the changes that we want to see? Are there any unintended consequences? So we know, for example, that some of the messaging in anti-stigma work over time hasn't had the desired change. In fact, it may have driven stigma in the other direction. So how do we make sure we avoid any of those pitfalls? And also, are there any critical issues or actions to address stigma and discrimination that perhaps we've missed and haven't dealt with in a lot of detail? So there are a number of kind of different perspectives that we're seeking through the public consultation period, so that we can kind of explore all of these issues as we work to finalise the strategy itself. So we'll come back to this at the end, because we really want you to have the opportunity to hear from Tim, from Margaret, from Tony, and from Kevin, who've all been involved in this work. But I wanted to say a very personal thank you to everyone who has been involved in this process so far. People who have challenged our thinking, who've encouraged us to look in directions that we may not have looked at otherwise, and to really recognise that for our team has involved really grappling with complexity. And I can see in a couple of the questions that are coming through from people on the Q&A, and as Emily said, we're going to grab each of those questions and make sure we respond to these. What we're trying to do here is to grapple with a topic and an area that is particularly complex, that there are very different views on what's helpful and what's not helpful. There are different ways of people making sense of their experience, and language is particularly critical. So there are certainly, for some people, biomedical understandings of mental ill health and distress have been useful. Diagnostic labels have been useful. For other people, they've been quite distressing and quite harmful. And so we've really tried to grapple with all of these different perspectives as we've been doing this work. And so we're really grateful to everyone who has encouraged us to flesh that thinking out a little bit further, and to really grapple with it in a way that we hope is really meaningful, and we hope moves the conversation around addressing stigma and discrimination along a little bit further. So I'm going to stop there and hand back to Emily, so that you get the opportunity to hear a little bit more from others who have been involved in helping to create this draft strategy with us.
Thank you so much, Michelle. And I'd invite our panelists to come onto the screen as we kick off into some reflections. So I'll hand over to Tim to provide some reflections from a personal lived experience perspective. Thanks, Tim.
Thanks, Emily, and thank you, Michelle. It's really wonderful to be here at this stage of the strategy's development. And picking up on Michelle's point, I really encourage people with lived experience, especially personal lived experience, which is my point of view, to engage with this consultation. I think we often have that mantra, nothing about us without us. And it's really important that we make sure our voices are heard. And the poetry is a wonderful medium. I remember one of the defining moments of my recovery was writing quite a long poem called Reasonable Delusions of a Religious Nature, which outlined my initial experiences with mental health and helped shift the stigma I felt about myself at the time. I think we have the words biomedical model. I think in the old days, it's almost 40 years since I entered a mental health unit with psychosis, and it's an alleged science around mental health. We used to think that this was a degenerative brain disease that we suffered from. So, my mother shared with me about 8 or 9 years ago when she met with the treating doctor back in 1983. She asked, "What's Tim's prognosis?" And the doctor said, I come from a family of 6 kids. Mrs. Heffernan, thank Thank goodness that you've got five good ones at home, or 5 good ones left, I think she said. So, you know, often for many of us, we've started from that viewpoint of reduced expectations that have been imposed on us by a system that was meant to help us. And we've carried that all our lives. That's gone into our work. You know, I couldn't have got back to work as a teacher unless I left off the fact that I'd had a mental health issue off my resume. I couldn't be open and honest about that. At the end of my teaching career, the fact that I had a mental health condition almost stopped me getting workers' compensation that I deserved and fought for. I think, you know, we've reached a stage, and this is part of the strategy. The strategy is built on lived experience. It has lived experience. If you look at all the actions, we are building structures to fight the structures that have worked against us. You know, we have recommendations around what we've wanted for a long time, the national peak bodies and a professional association. We're looking at recommendations about really scaling up the lived experience workforce across not just mental health, but across all other social and sectors of where people work and come into interaction with people with lived experience. And we're looking at a depth and diversity of the lived experience workforce that represents, meaning that everybody has someone who is like them in this space. You know, we have things that are illegal happening. We've got the Universal Declaration of Human Rights in 1948. We've had the Convention of People with the Rights of People with Disabilities more recently, and we still have these things happening. So why is the strategy necessary? Well, it's still going on, and I think that's incredibly important. And I do hope that you can look at the actions, at the whole strategy, and please feed back to the Commission and help shape this thing. You know, once when I was walking around Sydney in a bit of a manic state, not harming anybody, but having a good time, I came across a gate in the Opera House, and inside the jacket was a quote from Anais Nin. Life shrinks or expands in proportion to one's courage. It is a time for us to be courageous and to really reduce and hopefully sometimes delusional and stigma and discrimination. So I'll pass back to Emily, who will introduce the next speaker, I think. Okay, Emily, thanks.
Thank you so much, Tim. Really words from the heart. Margaret, ask you to step through from your perspective.
Thanks, Emily, and thanks, Tim. And I would also like just to acknowledge the traditional custodians of the land from which I'm meeting with you today over here in Perth, WA, the Whadjuk people of the Noongar Nation, and pay my respect to their elders past and present, and note that this land was never ceded. And so I bring a living experience as a family member of a couple of much loved folk who between them have navigated a range of systems, including mental health, alcohol and other drugs, physical health, criminal justice, including prison, and most recently NDIS, which takes us into a whole new galaxy. My experiences of stigma and discrimination as a family member came way before I would have named the experiences in that way. Those terms seemed really big for the multiple small acts of disapproval, disrespect, and disdain that we experienced across those multiple systems. The random acts of unkindness were more like paper cuts than stab wounds. But I came to know that death by 1,000 cuts is a very real thing. When I first heard the research findings as a member of the Public Stigma Technical Advisory Group, I cried, which for people who know me is not a common occurrence. I did so not just because the picture the research paints is confronting, but also because it was so validating of our experiences and actually gave concepts and language to them. And I acknowledge that I speak from a cisgendered, middle-class, English/Irish speaking white perspective, which in itself is a privileged perspective. As a family member, I found there to be a double distress for me around discrimination. There's the emotional and mental distress of witnessing someone you love being treated badly and having largely ineffective ways to remedy that treatment, which don't put the person at risk of losing their supports or actually make them more unsafe. And then there's the distress that comes from being on the receiving end of unchecked assumptions and behaviors that indicate that you are clearly seen as deficit and somehow to blame as a parent or a partner, and having to think at that quite distressing time whether you've actually got enough time or energy to pursue a complaints mechanism in which you might have little confidence that will provide any useful outcome. And the impact of holding all of that can be significant. And those impacts are why it's important for stigma and discrimination, intentional or otherwise, to be named up, addressed, and eliminated. And in true Irish style, I was thinking of a story when I was thinking of what I might share with you today. And this isn't an easy story, but it is a true story. And it's something that I witnessed only 3 weeks ago in a local emergency department on a Friday night, because you never end up in an emergency department on a Monday morning at 10 o'clock. And it shocked me, even after 20 years of navigating these areas, and it grounded me again in the importance of this work. I was there with Joe, a family member who's often had difficult experiences at EDs, and so I go with him, sometimes as a buffer, but too often as a shield. And across from us, there was a homeless man in his 50s, clearly from an ethnic minority background, who was quietly dozing in his cubicle. And he became increasingly distressed over the time. I noticed him slipping out at one stage because, as it turns out, to actually get his tent. During that time, his attending nurse walked around loudly, saying to no one in particular, "Have you seen my drunk patient?" Sometime later, after his return, another nurse, who was also now Joe's nurse, gave him a loud lecture in which she said harsh and unhelpful things like, "Your family are sick of you. Of course they don't want to talk to you anymore." I couldn't help myself. I approached her and asked why she thought it was okay to speak to someone like that and what authority she had to speak on behalf of his family. She looked shocked, and she was only willing to engage when I mentioned that I was a trained alcohol and other drug counsellor. Clearly, my family expertise would not have been sufficient for her to listen to me. And why did I do that? It's not because I'm a particularly courageous or a good human being, but because I know Joe has recounted similar experiences to me too often in which he felt diminished and disrespected and alone. And I wish, as a family member, that someone would speak up for him if he had no one there. So we now all have the opportunity to speak up through this consultation. Please take it and share it. It is really important. Thank you.
Thank you so much, Margaret, for sharing that with us all and for making that connection to the work that we're doing. Really important. Tony, I'll invite you to speak next from that perspective of someone working within some of these systems.
Thanks, Emily, and thanks, Margaret and Tim, for your contributions, and also just to the Commission for undertaking this work and for inviting me and a number of other people on to be part of it. It's a real privilege. So, like Emily said, I'm a therapist, work with people who have a number of different issues, but predominantly addiction and mental health issues, and also work in state government services planning a service system for people who experience harm from gambling, which in this country in particular is a particularly stigmatized condition, partly because of cultural reasons, but partly because of the widespread prevalence of gambling. But I won't get into that today. So just a couple of reflections on the experience of being involved so far in co-chairing the Self-Stigma Technical Advisory Group, which in itself has been a real honour and a pleasure to work with those people. I think what I wanted to say first off was just that I think it's important to note that while public, structural and self-stigma are each sort of representative of specific processes and phenomena, then the benefits of a reduction, however small, in any one of these is mutual, which means to say that if we can shift the dial at all in either structural and or public stigma, then this will hopefully result in a shared improvement in self-stigma. But I suppose three key things for me that came out of the work that we've been doing to develop the strategy has been, from a practitioner's perspective, has been language training and the lived experience workforce. So language in particular, I think, is particularly important in this area. Language around mental ill health generally has come a long way, but there are still significant gaps. I think there's a recognition in the strategy that language can be divisive and alienating, and that's really, really important. And I think that's as important for practitioners as it is for people who present for service and support. As we've said, cultural change takes a long time, but if we've got a clear, consistent, agreed lexicon, this will have, I think, enormous benefits for how practitioners manage referrals, secondary consultations, and clinical work in general. People access and support will benefit from an engagement in a vocabulary which they might recognise and which understands them. Training for mental health practitioners, I think, is going to be incredibly important. There's been a long time where we've had a mental health system that's involved time poor, ageing workforce, many of whom rely on foundational training that's maybe been undertaken years ago, sometimes decades. This isn't a criticism in any way of people working in this sector. There's a lot of good people. There's a lot of dedicated people who do a lot of hard work. But I think the rollout of a stigma and discrimination specific training programme as part of this strategy can have a huge impact on practitioners, in particular with regards to the story that Margaret just relayed to us, but also some of the comments that the questions that people have been sending through, that their experiences have been that often practitioners don't use the right language and sometimes actually make things a lot worse with some of the ways that they approach people who experience mental ill health. And then lastly, just in the lived experience workforce, one of the actions is the development of a sort of a strategy for that, which is, I think, long time coming. I think for too long we've relied on people with a lived experience to fill gaps. It's not been a professionalised workforce, and by that I mean that there's not been, it's been seen as an add-on and a nice to have, but not as an essential component of care planning. I think that needs buy-in, and it needs clear governance and administrative support, and it needs to be more than an afterthought, and it needs to be considered at the design stage of any mental health system. So I really welcome that, and I hope that makes significant changes for people who practice in this area, including myself. Back to you, Emily.
Thanks, Tony. I'm really highlighting some of those systemic considerations, but really identifying that there's a process there and some cultural change to be working through at the same time that can benefit everyone. So finally, on that note around systemic change, I'll hand over to the Honourable Kevin Bell. And you're on mute, Kevin.
Thank you very much, Emily, and it's an honour to be here, and I really enjoyed listening to the previous speakers, and you can see how strong is the interaction and the collaboration between all of us, and we bring that sense of collaboration and mutual support to this presentation today. My perspective is fourfold. Certainly legal, as a judge of the Supreme Court of Victoria and other judicial institutions. It's academic, because I am a professor of human rights law, and I do bring to bear the learning from the Indigenous perspective that I've obtained by being a member of the Europe Justice Commission. But I'm also a parent of children with mental illness, one sadly passed, and the other having terrible difficulty obtaining housing in the current housing environment. And so stigma and discrimination in relation to housing is very present in my mind at the moment, and my heart goes out to all persons with personal lived experience confronting that difficulty now. all of these experiences have convinced me of the absolutely fundamental and foundational nature of human rights to any strategy to reduce stigma and discrimination. And the reason why human rights are foundational to any such strategy is because they enshrine values which are indispensable, values such as dignity, equality, and respect. And I think that we have really reached the stage now of understanding that stigma and discrimination represent the absolute negation of those values, with serious personal consequences to the individuals concerned. And just to refer to housing, how can you possibly live a stable life that has any chance of enabling you to achieve your full potential if you can't obtain stable housing? And any housing system that operates in a way that stigmatizes and discriminates against people with personal lived experience is one that doesn't deserve its name as a system. It's also the case, obviously, that the very function and purpose of human rights, the very nature of the mechanism, is to prevent that kind of negation of respect, dignity and equality from happening at any time and anywhere, so that there's this systemic element to human rights which fits really well with the systemic element of a strategy to achieve reduction in discrimination. Human rights also operate to help us understand, in the context of the administration and content of the strategy, that stigma and discrimination is not just a question of policy correction. It certainly needs that, but it's not just that, and it's not just a question of good administration, although it certainly needs that, but it's not only that. It's a question of justice. It's a question of vindicating the rights of all people, not because it's good and proper, though it is, but because it's just and required in any system that values them as equal human beings. In any system which pays respect to them equally with other people as members of the diversity of human experience. So this justice element is something that human rights brings to bear that would be lacking without it. The strategy is based on a premise with which I'll end because I see the time. And the premise is that poor human rights protections for people with personal lived experience are part of the problem of stigma and discrimination. And therefore correcting that, moving to a system where human rights protections are effective must be part of the solution. Emily, I think that's as much as I can say in the time available, and thank you for giving me that time.
Thank you so much, Kevin, and thank you all to Michelle, Tim, Margaret, Tony, and Kevin for sharing information about the strategy and your reflections. We really hope that today's webinar has been helpful for everyone who's watching both today and subsequently, in providing a bit of a bit more colour and movement to what is a very big strategy underpinned by human rights, but really with this as a genuine person-centred outcomes sort of goal that we're looking for forward to in reducing experiences of stigma and discrimination. Thank you so much, everyone, for your interest, to those who have been providing questions through the Q&A, and for everyone for giving up some of your time to join us today. As mentioned, this webinar recording will be made available online alongside a transcript of the discussion today. We really encourage everyone to get involved and provide feedback on the draft strategy. On our website, we do have the draft strategy in full, but there are a couple of other supporting documents that provide a summary of the strategy and a summary of the particular actions that we're proposing through this consultation process. And just a reminder that there's a number of ways that you can get involved to provide feedback. So there really is a role for everyone in reducing mental health related stigma and discrimination. And so we would really love to hear from as many people as possible from that full range of experiences and perspectives that are really needed to, if we are to reduce and eventually eliminate stigma and discrimination related to mental ill health. Thank you so much again. Take care, and we hope to hear from you soon.